Right, now, I think we ended with that last lecture right on just the control of breathing right here in terms of C3, C4, C5 keeps you alive. So let's continue here and talk about the plural system. Keep in mind that when we talk about the plurals right here, we have a combination of parietal pleura and visceral pleura. It's very similar to what we saw with the cardiac system when we have the visceral and parietal pericardium. Now, one thing to remember about the visceral pleura is a thin film of cells that are covering the external part of the lung. So the lung itself is going to be made out of these small microscopic alveolar cells. And then it has a thin film of simple squamous epithelium that makes up that visceral pleura. Now, one other thing we see is that the parietal pleura is actually found on the inside of the ribs. Here you can see is this kind of bright green area that covers the internal aspect of the ribs. It allows the ribs to be connected from each other. And if you've ever cooked ribs before, you'll notice that the inside aspect of the rib, there's like a continuous connective tissue that connects one rib to the next, to the next, to the next. That kind of tissue doesn't cook. So usually when we are kind of cooking a rib and cooking ribs for a recipe, you have to remove that thin film of, actually, I would say that's pretty thick connective tissue that's adherent to the inside of one rib to the next to the next. Now, that parietal pleura forms a seal on our thoracic cavity. The seal on our thoracic cavity right here then allows no air from the external part of our environment to go into your thoracic cavity. Now, what happens then is that space between the parietal pleura and the visceral pleura should just be free of air. It should be a vacuum. Now, it's important to have that become a vacuum because what we're going to see is as the rib cage expands, since there's a vacuum effect, the parietal pleura expands with the rib cage, which then allows you to pull on the visceral pleura. As the visceral pleura gets pulled over and gets pulled out, it allows the alveolar cells to be pulled out and expand as well. And in Boyle's law, we know that when there's an increase in volume, you'll have a decrease in pressure. The decrease in pressure then allows air to go from the environment into our alveolar cells. So let's take a look right here. And again, there doesn't need to be a huge difference in pressure. Usually when we talk about difference in pressure, it's a very small difference in pressure between the environment and our cell and the internal aspect of our lungs. So there's very low pressure difference, but as long as there's some pressure difference, you will have air movement. Remember, air, blood, water, all moves from an area of higher pressure to an area of lower pressure. Excuse me. So again, parietal pleura found on the inside, and it connects one rib to the one below it, to the one below that one, all the way down. It forms a water airproof seal on the inside of your thoracic cavity. The visceral pleura is found on the outside of your lung matter, your alveolar cells. So as you take a deep breath, your chest as well as your ribs starts to expand. As it starts to expand, you see an increase in volume. What happens then? Well, the ribs and the parietal pleura pulls on the visceral pleura, allowing now the lungs to expand. As the lungs and the ribs cause this expansion, there's a pressure drop in the lungs. The pressure drop allows air to go from the environment into the lower pressure of your alveolar cells. Now, when we do have a collapsed lung, what we call a pneumothorax, it can happen when you have a rib fracture. The rib is going to fracture internally, and since the fracture might have sharp parts of the actual bone going internally, it can cause a rupturing of the parietal pleura. If the parietal pleura is cut at all for any reason, there's free air that comes from the environment. That air then goes into that space between the parietal and the visceral pleura. That air now is trapped in that space. Now you have an obstruction occurring in that space. That obstruction then makes it hard, almost impossible, for the parietal pleura to pull on the visceral pleura. When that happens, your chest and your ribs might still move out, but now you can't pull on the visceral pleura because there's that obstruction of air in there. Because you can't pull on the visceral pleura, your lungs can't expand, even though your chest can move. Again, if your chest moves and your lungs don't expand, you're not getting air in. So that can cause death if it happens bilaterally. Now let's take a look at in terms of ventilation, right here, and in terms of blood supply. Now, in terms of blood supply right here, keep in mind, just like we saw in the heart, we have two sources of blood that goes to the lung. One that allows you to bring deoxygenated blood from your body through the right atrium, through the right ventricle, up the pulmonary arteries to the lungs. That's a normal source of blood so that we can oxygenate. Now, keep in mind that when this happens, you're not bringing actual nutrients and oxygen to the lung matter and the cells that make up the lung matter. So you need a second blood source that will bring oxygenated blood and nutrients to the lung matter itself. So the cells that make up the lining of the bronchioles, your smooth muscles that make up your bronchioles, your alveolar cells, well, those all require blood that contains oxygen and it's slowed down. That's where these bronchial arteries come in. Bronchial arteries are the second type of blood supply. Bronchial arteries allow you to bring blood and nutrients to the lung matter itself, and we're here targeting cells that are very similar to what we saw with the vasovasorum. So the cells that are going to be active, so then we can have gas exchange, the alveolar cells, they receive blood through these bronchial arteries. They receive oxygen from these bronchial arteries. Now, you will see next, for some reason it's going super fast. You'll see next then, what we're going to see next is, all right, so moved up a little too much here, so we're just going to move it up a little bit more and talk about ventilation. Now, keep in mind when we're talking about normal, quiet breathing. Normal, quiet breathing is basically just due to your diaphragm, and it's all dependent on this, Boyle's law. Again, the higher the pressure, the more air moves from higher pressure to an air of lower pressure. Now, we're not going to affect the pressure in our environment. The environmental pressure is going to be 1 atmosphere, no matter what. The only time it changes is if you go uphill or you're going and climbing a mountain. As you climb mountain, well, there's less air, so then the pressure is going to be decreased. As you go down lower, there's greater pressures. So then there's more atmospheric pressure being exerted on us. Now, in terms of air movement, we somehow have to cause a change or a drop in our pressure, all right, and the pressure in our lungs. We follow the same, law that we see in chemistry, Boyle's law, where pressure of a gas and the volume are inversely proportional, meaning that as we increase a volume of a gas, the pressure is going to drop. As you decrease the volume of your holding tank for a gas, the pressure is going to increase. Keep in mind the example I use is like this. If you have a 10 gallons of propane and you put it in a 10-gallon propane tank, what happens? Well, that's a very low amount of volume. So the pressure is going to be increased. Again, 10 gallons of propane, you have about 10 gallons of the gas. Right? Now, what happens if you put that same 10 gallons of propane in a 100-gallon tank? We still have the same amount of propane, but now we're putting it in a larger tank. The volume increases then, and the pressure drops. So keep in mind, there's always that inverse pressure, and now it's up to our body to cause changes in the pressure within the lungs. And we do that by changing the volume. We take a deep breath, you have a large increase in lung and thoracic volume. As the volume increases, so your thorax, your rib cage increases in volume first. As that increases in volume, you will then have the parietal pleura pull on the visceral pleura, causing the lungs to increase in volume as well. As there's an increase in volume, there's a decrease in pressure in the lungs. Now there's less pressure in the lungs than in the atmosphere. Air is going to go from high pressure, atmosphere, to lower pressure, lungs. Perfect. Now, all of that is dependent only on the diaphragm during quiet respiration. So when you inspirate, the diaphragm contracts, it flattens, it allows the rib cage to increase size. When you have quiet expiration, it is also due to the diaphragm. The diaphragm is going to relax, move up. As it moves up, it causes a decrease in volume in the lungs and the thoracic cavity. That decrease in volume causes an increased pressure, which allows you to move the air up. So here we're just kind of showing you the numbers here. Not very big numbers. So we've just done breathing. What happens is we just exhale. Now there's the same pressure in the lungs as in the atmosphere. Again, you just exhale out. Now you're going to take your next breath. As you take your next breath, the thorax expands, the rib cage moves outwards, your parietal pleura pulls on the visceral pleura. So then the movement of the thoracic cavity is going to cause movement of the lungs. So everything, including the lungs, expand upwards and outwards, increasing the volume. As we see an increased volume, notice that now we see a decrease in pressure. And the pressure now becomes -1. As the pressure becomes -1, over here, there's negative pressure. And with that negative pressure, we will see that air is going to go from higher pressure to the lower pressure. Perfect. That's inspiration. Now, as we expirate, exact opposite thing happens. As we expirate right here, as we expirate, the actual lung matter will then decrease in size, decrease of volume. Decreased volume means I increase the pressure. The pressure goes from -1 before to +1. Now there's more pressure in the lungs than in the atmosphere. The lung pressure will allow us to expel the air out and allow us to expirate. So in a nutshell, that is how we are able to inspirate and expirate. And usually when we have just quiet expiration, quiet inspiration, it's always due to just a diaphragm. We'll talk about later how we can get other accessory muscles to work. Now, changing up the alveolar volume, and especially we're going to see when we expirate or exhale, we need the activity of our elastic fibers, right? The elastic fibers allows for elastic recoil. Think of this as a balloon. What happens when you blow into a balloon? Well, you blow into a balloon is pretty, right, it's going to expand. If you don't put your finger and your thumb and finger on the nozzle, if you let go of the nozzle, all the air moves out quickly because of the elastic property of the actual latex balloon. Now, we have this something very similar to that. We have lots of elastic fibers on the alveolar walls. So as we expand the alveolar cells and their walls through inspiration, we increase the elasticity. So then we expirate, the elastic fibers are like springs. They collapse and then they allow you to push that excess air out of your throat and into the atmosphere. Now, we will also see that there's surface tension as well, right? Surface tension is greatest where the water interfaces with air. Polar water molecules have great attraction for other polar molecules, and it's going to allow us to pull things inwards or collapse it. Right? There's a tendency for these alveolar cells to collapse as a result of this. Again, I want you to think of these alveoli as small balloons. If you guys ever blown and try to blow up a small balloon, it's really hard because of that surface tension between the latex. So in order to actually blow it up, sometimes you have to stretch it and then really put a lot of effort into starting the process of blowing it up. Once you kind of stretch it and you start the process, it's much easier for you to move more air into the balloon and blow it up completely. Now, unlike a little balloon, we cannot stretch our alveolar cells. So to decrease the surface tension, we produce something called surfactant. Surfactant is produced by a specific type of cells in our lungs called type 2 pneumocytes. These type 2 pneumocytes are going to produce surfactant, and surfactant is going to decrease the surface tension, making it easier for your alveolar cells to inflate. Now, we know that in kids, in preemies, if they're born before 6 months, the lungs haven't had a chance to develop. The cells, these type 2 pneumocytes, haven't had a chance to develop. The problem with these kids is that without the type 2 pneumocytes, it's like trying to blow into the smallest balloon possible without stretching it out. And what happens? These kids can't do it. These little babies can't do it. And preemies have a hard time breathing as a result of this. In the old days, the only thing we could do was just give them pressurized oxygen so then we can just inflate their alveolar cells through just pressure. The problem with that is we give them 100% oxygen, pressurized, and eventually it can cause a little bit of a gas emboli to occur in the eye. And some of these preemies would go blind as a result. So we can't just keep doing that. We found out a good way of producing surfactant. So what we have done now is produce surfactant. Surfactant then is introduced to the preemies respiratory system, and the now human-made surfactant acts like the baby's own surfactant, decreasing the surface tension, decreasing that recoil, so then it's much easier for the alveolar cells to expand. Now, we will see something like this as well in adults. In babies, we call it the infant respiratory distress syndrome, where not enough surfactant is produced. Here's our normal breathing cycle. Notice that you have this kind of inwards inspiration, right? And with inspiration, it's not a straight line. With expiration, it kind of is. And it's because of the relaxation of the diaphragm. The diaphragm relaxes, it allows you to expel air in a nice rhythmic way. Now, what else do we see in terms of lungs? Compliance. Measure of the ease with which the lungs and the thorax expand. The greater the compliance, the easier it is for a change in pressure to cause expansion. The greater the compliance, the healthier the lung. Just keep that in mind. Whenever we see any of the diseases we'll talk about later, we're going to see decreased compliance. Now, we know with coronavirus, people with pre-existing lung diseases are really susceptible to really devastating results of corona. So people with pulmonary fibrosis, they have decreased lung compliance because you have deposition of other fibers that are inelastic now in the lungs. Normally just have elastic fibers. Now can you imagine what happens if those fibers disappear and now we have collagen fibers? Makes it harder to inflate the lungs and to actually move the lungs. Pulmonary edema or water in the lungs will decrease lung compliance as well. So anything that will decrease lung compliance will signal a bad lung or lung disease. We want nice, healthy lungs with increased compliance. Increased compliance means that you're able to expand the lungs in the thorax, allowing you to increase the volume easily, allowing you then to decrease the pressure easily as well. With the decreased pressure, air now goes from the environment into your lung matter. Perfect. Now, in terms of measurement of lung functions, I just want you to know a couple one of these. One, the residual volume and the tidal volume. Tidal volume is just normal inspired and expired air with each breath. So let's show that chart again right here. Here is our normal tidal volume. On a normal semester, I'd actually have us test this. We have really good BioPack machines that does this. It'd be kind of cool, but I don't think we have a chance this semester. So normal tidal volume is just quiet breathing volume. 1,000 milliliters out, 1,000, let me phrase that, 1,000 milliliters in, 1,000 milliliters out, 1,000 milliliters in, 1,000 milliliters out. Or again, 1 liter. So perfect, right? Now, when we start taking a look at, actually it should be half a liter. Sorry about that, 500 milliliters. Now, what I want us to understand is that we have something called the residual volume. Residual volume is the volume still remaining in the respiratory passages after the most forceful expiration. So you've just taken a breath in, you exhale it out, and then you push as hard as you can, as much of the air out as possible. Right? When you push that extra amount of air, right here, when we push that extra amount of air right here, you'd imagine that we're at this very low point. There's nothing else in our lungs because we already have normal exhalation, and now we can exhale even beyond normal exhalation. We call that maximum expiration. Well, we actually have a little bit of air still left in there, right? That we are not going to be able to get out. That's called the residual volume. No matter how much effort you try to exhale that residual volume out, it will never come out. That residual volume is incredibly important because that residual volume is going to let us, the residual volume, sorry about that, is going to let us make sure that here, right, this residual volume is going to allow us to make sure that we do not have a collapse of our airways. There's always some air in the alveolar cells. There's always some air in the bronchioles. So then you don't have like a closed system and you have to go from a zero opening of the bronchioles and zero opening and collapse alveolar cells, right? It'd be very hard to do that. So what happens is we always have some residual amount of air left. That residual amount of air left allows us to have a little bit of air in the lung. So then when you take your next breath, there's always a little bit of air in there. The alveolar cells are already slightly stretched out. It's not as hard to take your next breath. That's why the residual volume is important. It's a volume of air in the lungs and the alveoli, and it prevents the total collapse of the airways. Now next, we'll talk about the dead space, right? There's anatomic and physiological dead space. Anatomic dead space is important because it should be the same for people depending on their age. It should be the same for people depending on their health. And their height. Height plays a big role in it. Anatomic dead space is any region of the respiratory system that does not have an alveoli. So it's your throat, your pharynx, it's your larynx, it's your trachea, it's your primary, secondary, tertiary bronchi, it's your terminal bronchioles, right? And then those are all anatomic dead space. Anatomic dead space is just dead space where air is moving as it enters your lung, as it enters your nose and mouth, as it's going to go into your alveolar cells. There is no gas exchange, it's just movement of air. Now, the respiratory system is primarily talking about areas of gas exchange. So in the respiratory matter, that's your alveolar cells, your respiratory bronchioles, and your alveolar ducts. All of those three parts contains alveoli. So those are areas where you'll have gas exchange. Anything besides the alveolar ducts, the alveoli themselves, and the respiratory bronchioles, right? Anything besides those three have no alveolar cells. So there will be no gas exchange in those other areas. and those other areas are called the anatomic dead space. The physiological dead space is dependent on your health. So the anatomic dead space usually is dependent on your height, your weight, that kind of stuff, right? So somebody of the same weight, of the same height, should have very similar anatomic dead space when comparing two people. Physiological dead space is different. That compares health. So if you have somebody that's 5'7", 160 pounds, you have another person, 5'7", 160 pounds. They should have the same anatomic dead space. But now we're going to add the fact that the first person, 5'7", 160 pounds, he's a smoker and he's got pulmonary fibrosis. The second person, same height, weight, is an athlete. He doesn't smoke, anything. So he's not going to have any lung disease. The first person that has lung disease are going to have more physiological dead space. So their total dead space is going to increase. In other words, because their dead space increases, they're going to have less gas exchange, making it harder for air to move into the red blood cells. Now, the second person is perfectly healthy. His physiological dead space is identical to his anatomic dead space because the lungs are healthy, there's no loss of alveolar cells. The only dead space he'll have then is the anatomic one that everybody has. So you want to be non-smoking, so then your physiological dead space equals your anatomic dead space. If you're a smoker and you have some kind of pulmonary damage, you will have more physiological dead space, right? Add it to the anatomic dead space, and now you have less lung matter for gas exchange to occur. Now, in terms of Dalton's Law and Henry's Law, Dalton's Law basically refers to partial pressures of a mixture of gases is the sum of the individual pressures of each gas. Now, I will have a whiteboard next week, coming on Friday, and it's much easier to discuss Dalton's Law with a whiteboard. It basically tells us that with Dalton's Law, each individual gas exerts a certain kind of pressure, and that pressure is dependent on the amount of that gas as a percentage and the total amount of atmospheric pressure we feel. So when we are at sea level, we have 1 atmosphere pressure. So all the nitrogens, carbon dioxide, oxygen, water vapors, all of them add up to 1 atmosphere pressure or 760 millimeters. Now, what happens when we climb a mountain? The air is thinner. So then there's less atmospheric pressure. So instead of all those gases adding to 1 to 760, it might add up to 400 or 380, half of what we see at normal sea level. If now you've half the amount of air and air pressure, it makes sense that there's less air, less oxygen as well, making it harder to breathe when you're at higher sea levels. Now, again, I'll discuss this more when I have my whiteboard next week, so then you can actually see the numbers a little bit better. Diffusion of gases is Henry's law. Henry's law is the reason why we can't just put oxygen into liquid form. We've heard of carbonated beverages before. Carbonated beverages are found in our sodas, right? It's found in our beer. That carbonated beverage is due to carbon dioxide, the gas being introduced into the liquid. Carbon dioxide is about 20 times more soluble as a gas than oxygen. Henry's law tells us the ability of a gas to go into liquid form. In other words, can carbon dioxide go into liquid form or can oxygen? We're going to see that oxygen has a much lower, very low, right? Diffusion ability as a gas into liquid. Oxygen is so low that you have to increase the pressure tremendously just to get a little bit of oxygen to go into liquid form. That's why you never heard of oxygenated beverages. Right? Carbon dioxide, 20 times more likely to go into liquid form. So if we want to make a beverage like our soda, we'll actually put carbon dioxide gas into the liquid. As we introduce that carbon dioxide gas in there, carbon dioxide was more readily going into the liquid, allowing us to see that fizzy part of the gas. Every kind of gases is going to have different solubility. right? The greater the solubility coefficient, the greater the availability of that gas to go into liquid form. Now, most of us are not worried about sodas. We can talk about our bloodstream. Our blood is liquid, right? So what happens is we can't sometimes put certain gases into liquid form. Carbon dioxide is going to be carried from your tissues where it's produced, and it's going to be carried into your lungs about 7% of the time as a liquid gas. Pretty cool, right? We're not going to see the same thing in the oxygen. Now, we'll talk about Henry's Law specifically in terms of how it relates to problems with, right, especially with problems with bends and people who are, and you probably heard of people that are uh, diving, right, deep sea diving, people, all right, that are scuba diving, having the bends. This is where Henry's Law comes in. Come back to Dalton's Law again, probably on Friday, as I put in another lecture in there. Now, in terms of gas exchange, the principles of gas exchange requires diffusion of gases through the respiratory membrane, right? So the respiratory membrane is a membrane which air, oxygen, carbon dioxide has to go through. So it makes sense that in order for gas exchange to occur and for greater gas exchange to occur, we want the membrane to be as thin as possible, meaning that, right, when we look next right here, right, so we want decrease amount of obstruction for gas. Again, you're introducing oxygen and atmosphere gases into your alveolar cells. Oxygen then has to go through the simple squamish cells that make up the alveoli. Then it has to go through the basement membrane, keeping those cells together. Then it's got to go through the basement membrane of your capillaries. And then it's got to go through the simple squamish epithelial cells that make up your capillaries. So you have 4 different components for oxygen to have to go through. So the thicker that membrane is, right? So the membrane is formed by the alveolar cells, the basement membrane, keeping the alveolar cells together, the basement membrane keeping the capillary cells together, and then your simple squamish epithelial cells that make up your capillaries. So that's 4 different areas that make up the basement, that make up our respiratory membrane. The thicker the respiratory membrane, the harder it is for gases to go through. What else? Diffusion coefficient of gas, right? Some gases diffuse much more easily. Carbon dioxide is one of them. Carbon dioxide goes right through, goes right into liquid form much more readily versus oxygen. Then surface area, right, also allows us to have increased or decreased gas exchange. So surface area, diseases like emphysema, lung cancer, lung disease, pulmonary fibrosis, all decrease the availability of alveolar cells. They kill them. Because they kill them, you can have decreased surface area for absorption. Decreased surface area, decreased amount of gas exchange. And then partial pressure differences. Gas always moves from area of higher pressure to area of lower pressure. And what we're going to see is this right here. As we go into the lung matter right here, right? The oxygen in our blood is going to have a PO2 of 40. What happens then? Well, that's pretty low. Why? Because that blood has just gone through our tissues. That blood, red blood cells, have given about 30% of their oxygen away. As they give the oxygen away to the tissues, right here, it makes sense. The oxygen's been given away. So you have less oxygen in the blood. So we take it back to the heart, back to the right ventricle, and now that low oxygen blood at 40 millimeters of pressure is going to be close to the alveolar cells. The alveolar cells has just received oxygen from the environment. That oxygen just enters the environment and go into the alveolar cells, expand the alveolar cells, and that oxygen coming from the atmosphere has high oxygen content, 104. Big partial pressure difference, 104 in the alveolar cells, 40 in the red blood cells in the capillaries next to the alveolar cells. What happens then? Gases want to go from higher pressure to lower pressure. There's more pressure of oxygen in your alveolar cells, less pressure in the blood. So oxygen is going to go from high in your lungs to low in your bloodstream. And you're going to have more gas exchange as a result. Again, the greater the difference in the partial pressure of a gas, the more gas exchange there will be. Now, if you look at carbon dioxide, take a look. There's not much of a difference here in the lungs. 45 partial pressure in the lungs, in the pulmonary capillaries, 40 inside the alveolar cells. Meaning what? Very small concentration difference. So we do see some movement here, but what we're going to see is carbon dioxide is more diffusible. So even though there's only a very small difference, right, because it can go through easily, you'll have carbon dioxide being exhaled out into the alveolar cells much more readily as well. Again, when we're looking at PO2, PCO2, the P means partial pressure. The P is a way of measuring also the concentration of a gas. When we measure the concentration of a solute, we use moles. We can see it. We can use moles. In terms of a gas, we can't see a gas, but we can feel the pressure it exerts on us. So instead of using moles, we use pressure. The more of that gas, the more pressure it exerts on us. And the last thing I'll talk about is this relationship between alveolar ventilation and pulmonary capillary perfusion. Now, I really like this chart because this is really telling us how we're able to survive when there is maybe a collapsed lung on one side, if there's a lot of health condition, pneumonia on one side. So I want you to know what this means, right? So let's talk about, and I'm just going to highlight these so then you can highlight it, and this will be the last thing I'll discuss. So what do we mean by the ventilation perfusion ratio? What we're going to see is the lower the alveolar ventilation, the less gas exchange. The less gas exchange there, well, there's no oxygen, no gas exchange. Would we want blood to go through those areas? No. So we want decreased perfusion in areas where decreased ventilation is found. Now, what will cause us to have decreased ventilation? We'll have decreased O2 or decreased ventilation when we have a collapsed lung, when we have pneumonia on one side of our lungs, right? Now, usually you don't have two collapsed lungs or else we're in real deep trouble, or bilateral pneumonia, and then we'll be in real deep trouble. So if one side's affected, what happens? There's no gas exchange on that side. Because there's no gas exchange, there's now very low oxygen, right? So the PO2, the concentration of oxygen in the side that's affected. So let's say my right lung collapse. That right lung collapse means there's no air going into the lungs. There's no oxygen going in. Because there's no oxygen going in, there's lower amount of oxygen, low PO2. Low PO2 in the lungs causes the arteries and arterioles to constrict. As the arterioles constrict, less blood flow occurs. Again, makes sense, right? The lower the oxygen in the lungs is a sign of some kind of trauma or damage. So the lower the oxygen, we're going to vasoconstrict. We're going then decrease blood flow to that area. The areas that do have better ventilation. So my right lung collapsed, no oxygen, I vasoconstrict, less blood flow to the area. The other side, my left side, has more oxygenation then because that side is unaffected. What happens then? Increase oxygen, I vasodilate, allowing me to shunt or detour blood. The blood that should go to the right side can't because the blood vessels are constricted. Instead, it gets shunted and detoured to the opposite side that's healthy. That way, I have increased perfusion in the regions with increased ventilation. And the opposite's true. You have decreased perfusion in areas with decreased ventilation. And again, perfusion means blood flow. It should make sense. I want you to think about it, right? If I have decreased air in one part of the lung, doesn't make sense to bring blood there. Why don't we bring blood to the good part of the lung where there's increased ventilation? That's all this is saying. Now, keep in mind, and we'll see this later, what happens in the lungs is different than what we see in our normal systemic tissue. In the lungs, lower PO2, low oxygen, is a sign of damage, is a sign you should detour blood. In your systemic tissue, like your muscles, right? Low oxygen in the muscles means that you're being active. The more active, the more energy. The more energy, the more oxygen you use, the more glucose you use because you need fuel. So the low oxygen in your systemic tissue is a sign of activity. Because of that, you need more blood to go into those active tissue. So in systemic tissue, low oxygen is not a bad sign. Low oxygen is a sign that you're being active. So in those tissues, you actually dilate. So it's completely opposite to what we see in the lungs. Low oxygen in the lungs, lung damage, you detour blood. Low oxygen in your systemic tissue, activity means you want to bring more blood to that area. You vasodilate. Perfect. Again, it should make sense. And I'll stop right here for now, and I'll continue on the next lecture.